It is my privilege to introduce Dr. Rachel Heilmann, who is a PharmD. In addition, so Dr. Heilmann is the Chief Scientific Officer for Med13L, who is another group out there. She has been staff at Combined Brain and has worked closely with us. If you've ever done a blood draw, you might have seen her in a costume taking blood out of your child, a testament to her care and love for our kids. She was the mother of a NARS1 child who was lost, so she understands our rare life, and she has given me countless hours of advice for free. And as the pharmacists in our community will attest, she is very good. So at my request, she agreed to give us this talk. And please welcome another rare parent and a generous, smart, and talented advisor to talk about something we all deal with or will, drugs. Thank you very much. Join me in welcoming Dr. Heilmann.
The green button?
Green button.
All right. All right, we're going to give this a go. So this is, I just did this right next door. So it's kind of a free-for-all. So I have basically compiled a massive slide deck of all of the, not all, I mean, I can't do all, but a lot of therapeutic classes that are used for neurodevelopmental disorders. And so there is essentially, I feel like I want this to be your encyclopedia because it's all in one place for seizure meds, stimulants, antidepressants, sleep meds, a handful of supplements, and some antipsychotics, just general drug knowledge, dosing information, common side effects, things to watch out for. And hopefully that'll help inform the conversations that you have with your care providers and make you feel a little bit more educated and empowered to advocate for the thing that's the best thing for your child, instead of kind of sitting there having to absorb all of it. And so that is really what this is for. And so I'm just opening the floor up to questions that they have particular to your kid or about a class of drugs. And then I'm going to try to find the slide in here and share it with you and talk through it. They gave me 50 minutes next door, by the way.
Time is tough here. Okay, so we'll walk around with questions, but maybe just to get them warmed up to the model. We recently put up a blog on our website about bones, bone density, and drugs that affect bone density. Can you talk a little bit about that? And then if you have a question, raise your hand and I'll bring you the mic. Any drugs?
I have a slide for that. So yeah, I wanted to comment on this because I have read the blog and of course I've referenced it here. So one thing to just think about seizure meds and a lot of drugs actually in general, especially as we use them in kids, is, you know, your skeletal bone development is happening at its peak, right, throughout your childhood. By the time we reach early adulthood, we're no longer growing, right? That's your baseline bone formation and density. So what's happening right now with your kids and how they're growing and developing, right, is setting the stage for the rest of their life. And so a lot of the drugs that are used are not quite as friendly on bone development. And the SRF blog does a really nice job of breaking it down and mechanistically just kind of what the thought process is on why that is. Medication culprits do just seem to be a little bit of the older classes, but I know valproic acid is a huge heavy hitter for use in a lot of the neurodevelopmental disorders and especially in DEEs. There are conflicting studies on lamotrigine as well. It's, you know, there's probably not just what's happening with reduced vitamin D availability, which is part of the metabolism pathway, and it can be interfered there, which now is triggering this feedback loop. So when you don't have enough vitamin D, calcium gets pulled out of the bone to get circulated in the system. So now you have weaker bones, and then you just do it all over again. The same thing with the calcium absorption. If you're having decreased calcium absorption, and especially if you're not nutritionally consuming enough calcium, because there's lots of calcium in our diets if you eat. And so that can be a struggle with a lot of our kids, is just getting food in their bellies, and of like high quality nutritious food. So I think and epilepsy has already been shown to be at higher risk for having osteoporosis and bone-related dysfunction already at baseline. So there's a lot of things kind of stacked against the wall when it comes to bone disease. There's not clear guidance on what to do to prevent that. My most helpful advice is, and I'm looking at Marta because, you know, she might ostracize me, but I think everybody needs vitamin D. We don't have enough vitamin D. We all slather ourselves in sunscreen. We can't consume any vitamin D. So we really have no way of keeping our stores up, of, you know, having a high quality. And vitamin D, not just from a bone capacity, can also help with inflammation and cognition and other things. I've used it when I used to do adult medicine in MS, and we used to crank it up really high, and it has some neuroprotective effects. So vitamin D for sure. Calcium supplements get a little wonky. We really want it to come out of a diet, but if we can't, then we want to try to get as much calcium in. And I would say a bunch of your kids probably need calcium. If they're not consuming calcium, you can usually get it in a couple servings of yogurt a day.
Thanks. I'm going to hit you with two questions. I'm going to ask you one, and then I'm going to let Braun ask you one. First question is, I have a lot of families who call me up and say, what's your favorite drug? And many of our kids are well supported on Epidiolex and Onfi, but those are second line, and first they have to go through first lines.
Yep.
I would love to hear a grown-up and a professional explain that, because I want to copy you. That's question one. And question two, and just how parents should think about first, second, and third line drugs and the need to fail. And then here's Braun.
I just wanted to clarify, if it's a vitamin D issue, vitamin D supplements, would they be helpful?
Are they helpful?
Yeah.
Yep. Wait, which question do you, I'm going to answer vitamin D first. There's still, so anytime we start looking at supplements, right, we get a lot of conflicting information because the way that the trials are designed, right? They're, you know, supplements are not regulated by the FDA. The rigor in which those trials are done does not meet the same standards as the FDA. So we always get a lot of information that butts heads with each other. So that's the first caveat. But my answer is, for me, vitamin D is something that is almost impossible to overdose on, and is very safe. So long-term benefits likely outweigh like long-term harms or risks. So that's kind of where I stand on vitamin D. And we aren't getting it from anywhere else. I would venture to say if we walked in and got our lab drawn, all of us would be at 20 or less.
On valproate, would taking vitamin D mitigate some of the bone issues?
It could, yep. So if you're able to sort of maintain, right, and supplement your bone health, right, it can help sort of counteract the detriment, right, that's occurring with valproate, which is constantly like ushering, right, things in and out of sodium and calcium channels. And so anytime, like, I feel like anytime you're moving electrolyte things around that are very, very sensitive, you're going to start mucking with things that are all over your body.
It's probably not. So can you talk now about first line, second line, third line? And then if you have a slide on TCAs, that would be cool.
I didn't put one in here, but I can talk about them anyways, just because TCAs have largely fallen out of favor, but I know that's something that's very specific to the Syngap community. So first line, second line. So I think when you just think about, hold on, I do have like a really high level little chart here on just like seizure choices. So this is guideline based, and what you do see here is really these really broad spectrum anticonvulsants, right? So the valproic acid, the lamotrigines, all of the big heavy hitters that do multiple things in the brain. They've been considered first line for so long, partially because when they were developed and partially because the way the trials were done. So once some of these newer drugs have come along, like Onfi, like clobazam, like Epidiolex, they're studied in conjunction with these. So they don't really get studied as a monotherapy. They don't really get studied as a single drug or as an intro drug. They get studied on top of these because these have been around for so long, and the ethical issues that come along with running untreated seizures, basically. It doesn't mean that they don't work alone. It doesn't mean that they aren't effective alone, or actually a better choice because they're more directly associated with, tampering down the excitatory or revving up the inhibitory process. It just means they weren't studied that way. And so that has created, sort of the circle of using older drugs first because of how they've been weighted and how they've been set in guidelines. But I agree with that. Even my daughter, we went through 3 choices before finally we got her on clobazam and changed her entire seizure burden.
I'm going to keep asking you questions until people raise their hand. On the top of that first pink box, I'll come over there. There's brivaracetam, which is a next-gen Keppra. Could you explain the difference between Keppra and that?
I can.
Why some people might want to ask to be upgraded?
Yeah, it's a great question. So brivaracetam is, both of those actually work in the same way. It's an analog of each other. I put it in here. Where is it? There. So I highlighted on the slide here things that are related to each other are different colors and are paired than what the header is. The differences between the two is actually it binds really, really tightly to the SV2A vesicle receptor. So because it binds so tightly there, it doesn't have as many offshoot effects, which is what you see with Keppra. And so the behavioral components and side effects that you're seeing with Keppra can be much more mitigated. So from a risk potential, this is something that actually could benefit your kids and control their seizures without, the aggression ramp that we see a lot, and not just in Syngap, but SLC6A1 kids have it, CTNNB1 kids have it, the same thing where Keppra is it's just not good for the side effect potential.
Thank you. So if we're on Keppra and it's working, but we're having behaviors, we can ask the brivaracetam and expect the behaviors to go down while still seeing the benefit.
You might not see the behaviors go down, you just won't see them ramp up.
That's a good answer.
Yeah.
So one of the things that was on there was cannabinoid oil, and just looking at Syngap studies, there was a study in mice that where in younger mice, they see the upregulation of Syngap proteins, but once mice reach a certain age, they basically don't get that same upregulation of the Syngap protein. Is that something that people should be thinking about as their child gets older if they go on cannabinoid oils?
Yeah, so I think cannabidiol and cannabinoid oils are probably a 2 separate conversations, just in terms of the way they're studied and probably purity levels and all the other things that kind of come along with it. I haven't specifically put cannabinoid oils in this presentation, even though I know it's used in the communities, and it's just, I think we're just getting started there. And so even with Epidiolex, we're just getting started with understanding and knowing what the endocannabinoid system does and what it controls. I think it is very possible that over time those things wane. And some of that might just do with what those receptors are doing in our bodies, or it could just have to do with a tolerance that's developed that we don't understand.
Okay, we got 5 minutes left. I got a hand. while I'm walking over there, a lot of our patients are on Onfi and Epidiolex, and because they potentiate each other.
Yep.
What does that mean? How does it work?
When I think of it means they're working in tandem to each other. So Epidiolex actually can increase the level of clobazam, and so when you're using those together, right, you're kind of getting a 2-for-1. So you might actually be able to use a lower dose of clobazam and get a similar effect, and maybe with a little bit less sedation or drowsiness because it's working directly on the GABA receptors. Yeah, it's a nice combo.
Can you please elaborate a little bit on liver disease and seizure medication?
Liver disease and what was that?
And seizure medication.
Oh, sure. Yeah. So this is especially common in the older drugs. So carbamazepine, phenytoin, phenobarbital. We are definitely with valproic acid is something that we should all be cognizant of. So when I think about valproic acid, especially over a long period of time, the things that I have seen are blood dyscrasias. So your CBCs, so your white blood cells might be too high or too low. Sometimes we'll see changes in just the red blood cell size and differentiation. Liver disease, so ALT, AST should be monitored at least yearly and very early on in the titration process to make sure that it's not causing elevations. And then the last thing I'll even say about valproic acid that I forgot to throw in with the bone thing is ALK-Phos. It's an easy lab to get, and it's not super specific to bone, but it can give you a nice insight to what's happening in the bone in addition to the liver. So you get a little bit of that. So those are some of the labs that I think about with that. But I would say valproic acid is probably one of the bigger risks now for liver problems.
Question about another medications that came as a third line, like memantine.
Yeah.
Potentiation of memantine, like for patients with cognitive problems.
Yeah, so I have a slide for that. It's really small, but I think, wait, I'm gonna find it. Wait, found it. There it is. There's not a lot of data out there right now with memantine, but I am particularly curious about memantine, amantadine, drugs that block and MDMA. So memantine is used right now for Alzheimer's and dementia, very, very early on to help with memory and cognition issues. I suspect that memantine, drugs that modulate acetylcholine, which is another neurotransmitter that is used or a lot for memory, could have some really strong and powerful benefits in our population. We just don't know enough yet, but like Mike, throw some drug on some cells. Let's see what happens. Craig, you're not allowed to ask me a question.
This is the perfect time. Going back to labs, valproic acid, doing like a trough level, dosing to a blood level versus therapeutic benefit, how often those things, and are there any other drugs maybe that we should be doing blood levels of those medications to monitor?
Yeah, so really the old ones, so the phenytoin, the carbamazepine, the phenobarbital, right? Those ones you definitely need to be monitoring drug-specific levels to. The data has gotten a little less clear with anything else. And a lot of that, like especially like lamotrigine, it's not a reliable marker. And so often people are overdosing on it. And so they're getting toxic on it because the level's not accurate. I would say valproic acid is somewhere in between there. It might help you. I would be more concerned on like more if it's you're getting toxic, right? Like liver issues or something like that. It's a good marker to tell you if you have too much, but might not necessarily inform your dosing.
So I got a hand right here, but I'm gonna ask one question first. A lot of our kids, we've talked a lot about seizure drugs. We haven't talked about behavioral drugs like guanfacine and guanfacine ER. So one question is, can you talk about the difference between guanfacine and guanfacine ER? And the next question is, if your psych gives you Abilify or risperidone,
Yep.
what are some things to be conscious of there? So two questions, the guanfacine and the Abilify.
Yep. So guanfacine, I actually think is probably a more valuable drug in a lot of these populations compared to stimulants, especially just because it's not really revving up your system, right? It's not releasing a lot of dopamine, which might not be great for some of the kids. And so it works centrally through a different mechanism and through the alpha-2 mechanism. And that helps to still release neurotransmitters, but to release them not affect dopamine, which is your reward center, right? It's basically, you know, if we all just snorted cocaine right now, and that's dopamine. That's what you do. That's what dopamine does. So go ahead, you tell your doctors all of that. I don't want my kid on coke. But with specific hyperactivity and difficulty with focus, it would be beneficial. But like, I think there's probably a lot of other underlying things that are happening where maybe that might not be beneficial for them. And then guanfacine, and then the second one was the antipsychotic class, which I typically like to think more of like a neuromodulators more than just antipsychotics. They were studied for schizophrenia and bipolar, but they have a broad base of really shifting, you know, those neurotransmitters. So aripiprazole and risperidone that Mike mentioned have been the most studied in children. Risperidone has the most data with the best effects on symptoms, but long-term, the metabolic risks. So we're talking about high blood sugars, lipids, especially triglycerides, blood pressure issues, massive weight gains. Like that is a very common thing that we see with risperidone. And so having annual labs and monitoring those things and seeing those things are super important. Aripiprazole or Abilify, less of all those metabolic issues. And then even the newer ones, lurasidone and paliperidone have even less effects. And so some of that is just some of the offshoot receptors that they're hitting that cause some of those.
Separately, should we all be giving our kids fish oil and other things that might be supporting brain? Like what other nutritional things can we do for like Syngap health?
Yep. So I have fish oil on here too. It's kind of my another one where I feel like it's not doing any harm. And so it can likely have some benefit, especially when it comes to inflammation. I don't know if there's any data on like sort of preventing the triglyceride rise that you might see as a side effect for some of these, but certainly is how we can treat high triglycerides and some effects too. So, but yeah, omega-3s or I prefer just EPA or DHA. It's just cleaner. It's than just plain omega-3s have a lot of health benefits. So it's on my list along with vitamin D.
Okay, your time. Thank you very much. I wanted everyone to hear this talk, because Rachel is just such a star. And if you get a chance to see her, you should thank her for everything she's done for our community. But also I want to emphasize we have two parents right here who are pharmacists and we should start hitting them up because how many people see a neurologist? Everyone's hands would go up. How many people see other kind of doctor? How many people have gone to their pharmacist and said, here's every drug my kid is on. What do you think? 3 hands, right? But these are trained professionals who are really smart that we need to take advantage of, because when you start having multiple people prescribing for our kids, it's worth stepping back and getting a fresh perspective on, okay, all these drugs are going into one body. What should we do? Would you agree?
Yes. And I would say, you're the pharmacist at the pharmacy, if you're going to the same pharmacy all the time, is running an interaction check every single time. And so that is like super, super important to recognize and realize, because these drugs do interact with each other. And so being able to go to the same place and have your meds housed in the same place will make a huge difference in terms of preventing a lot of the things that come with drug interactions, which are very unpleasant.
Very much. We are grateful for everything, Rachel, and I'm sure we'll see you again.
Yes.
And I want that deck.